Okay, well, welcome everyone to another dissertation defense in our program. And we actually have a couple more coming up this summer that you all should have gotten appointments for. So I am pleased to introduce Lily Cook, who to most of you on the call needs no introduction. She's been around the department for a number of years, and this is the final public step on her way to achieving her PhD. Um, Lily, and so then just to let those of you who aren't familiar with know how our dissertations work, I say this every time, but I'll say it again. Basically, Lily will give a presentation, and then we will open up to the public. All participants on the call are free to ask any questions. At that point, the public will be dismissed, and she'll remain with her committee, who may have some additional questions for her. And then she will be dismissed from the committee, and then the committee will determine whether or not she has successfully defended her dissertation. So Lily, as you all know, is a National Library of Medicine fellow, actually also actually funded by some separate funding we got from the National Institutes for Environmental Health Sciences. And she's pursuing her PhD with that fellowship. In terms of her past, she received a Bachelor of Arts in Psychology and Sociology from Wesleyan University, then received a Master of Arts in Counseling from George Fox University, and was in private practice as a psychotherapist for a number of years until she joined our program and decided to pursue a PhD and then joined our program. And so this is the last step. Well, the last public step. If she successfully defends her thesis, she will then need to write up her thesis, and then at which point we can call her Dr. Cook. So take it away, Lily.
Okay, thank you, Bill. So thank you all for coming, and today I'm going to be presenting my dissertation work on data quality and social determinants of health. So this is an important topic because there continue to be disparities in healthcare and health outcomes, and the COVID-19 pandemic has really driven home the relationship between health inequity and poor health outcomes. In fact, just about every metric that we look at with regard to COVID-19 confirms that we still have a lot of work to do to remedy these disparities. Whether we're looking at COVID case rates or hospitalization rates or death rates, or whether we're looking at access to vaccines. In order to document and better understand all the complicated factors that create these disparities, we need good data. Specifically, we need good data about social determinants of health. So there are numerous definitions of social determinants of health. The Center for Disease Control and Prevention relies upon what they call a place-based framework for their definition, and they state that social determinants of health are conditions in the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. And they add that most health inequity can be traced back to these social determinants factors. Both AMIA and the National Library of Medicine have been emphasizing social determinants recently because of how much these non-clinical factors and contexts influence patient health. But now that we've been using social determinants data more and more frequently, it's become more clear that this data is often very messy, and we don't have many good and who haven't formalized ways to improve it. If we're not careful about the quality of data, then we really can't know for sure that any conclusions we draw from it are valid. So the quality of social determinants of health data is an important issue because bad data can cause problems with bias, reliability, and validity in health equity research. My work moves us towards solutions to those problems by furthering the development of methods for improving the quality of the social determinants of health data that's used in health equity research. And I approached this problem by focusing on data quality improvement practices for real-world data, particularly looking at the data preparation process. So my first aim was to identify the data quality issues specific to social determinants of health variables sourced from the EHR. And this aim resulted in an article that was published in JAMIA. And I fulfilled this aim with a systematic literature review, or as I put it, I read 250 articles about social determinants of health, so you don't have to. So here's what I found. This table gives a breakdown of the content analysis that I conducted as part of that review. And that content analysis showed that articles about race and ethnicity variables have the largest body of literature. So my first major finding is that the quality of data about race and ethnicity is an important topic with a large body of literature. And the literature also showed that bias or validity issues often result from data quality problems. So a majority of articles either found bias when running test analyses on their datasets, or they noted that data quality was differentially poor for certain groups, meaning that there was a high potential for bias during analysis. And these data quality problems are not distributed randomly across groups. Data about Hispanic race ethnicity is especially prone to bias. The most commonly identified problem with race and ethnicity data was misclassification, which showed up in 19 articles. And 14 of those studies reported that Hispanic patients were more likely to be misclassified. 6 found disproportionately high rates of misclassification for American Indians compared to other racial groups. And the second most common problem with race ethnicity data is that it's differentially incomplete. In other words, it's missing not at random or MNAR. So data missing non-randomly like that means that it has a high potential for bias. So major finding number 2 here is that problems encountered with the quality of social determinants of health data are rarely distributed randomly. Certain groups are more prone to data quality issues, and this is especially true for Hispanic patients, but we also saw this with data from American Indians. So another major finding of the literature review was that although there are problems with data quality, there are also solutions that can mitigate those issues. 62% of the articles in the literature review made at least one evidence-based recommendation for users seeking to improve the quality of social determinants data after it had been collected. So I grouped those recommendations into 6 suggestions, which are shown here. The first one is to avoid complete case analysis, and kind of along the same lines, impute missing data. Also, number 3 is to rely on multiple sources of data, which I call triangulating the data. Also, number 4 is to use validated software tools. ArcGIS showed up a lot in that review. And select addresses thoughtfully. And 6, be transparent about any data quality problems. So major finding number 3 from specific aim 1 is that the literature contains suggestions on improving data quality. So there are problems, but there are also ways to mitigate those problems. And there were findings about social determinants factors other than race and ethnicity in this review. I also found that problems can arise with everything that's in that orangish color there, which is information that's derived by linking individual level medical records to community level variables like air quality or neighborhood socioeconomic status. In order to do that, we match the patient's home address to information about their neighborhood, which is called geocoding. And the literature review revealed that a couple of different problems can arise with that data. Primarily that rural data can be problematic and that environmental exposures can be misclassified. And the last major finding from specific aim 1 is that environmental and community level social determinants data, which relies on geocoding, it can have problems due to issues with matching and linkage. For example, rural data can be problematic. So my subsequent aims were informed by the findings from aim 1. And I developed the research project for the second aim around a unique opportunity that I had to work with the data in the National COVID Cohort Collaborative, or N3C. And this paper that I wrote to fulfill aim 2 was a collaboration with several members of the National COVID Cohort Collaborative Social Determinants of Health domain team. And I presented this at the AMI Informatics Summit in Chicago in March, and the full-length manuscript is currently in review with JMIR Medical Informatics. So the National COVID Cohort Collaborative Data Enclave, or N3C, is the largest collection of patient-level COVID data in the US and one of the largest such collections in the world. At the time that we conducted this research, the N3C contained data from 6.5 million patients tested for COVID-19 that had been collected by 56 healthcare systems across the United States. And the database has grown larger since then. And I refer to working with the N3C as a unique opportunity because the fact that this is a centralized database with data from healthcare systems all over the United States meant that we could show how the findings from my first aim generalized across different healthcare systems. So the background here is that each of these 56 healthcare systems contributing their data to the N3C has a slightly different way of recording and encoding that data. So if you just dumped all of the raw data from these different healthcare systems into a centralized database and you tried to do research on that, the data would be too noisy for any useful signals to emerge. So to make this data usable, it has to be transformed prior to that multiple times. And the process of transforming the data to a common data model in order to make it usable is called mapping or harmonizing the data. So to harmonize the data, hundreds of different encodings get distilled down to just a handful of concepts. And the National COVID Cohort Collaborative Data Enclave keeps the original source data essentially as it's given to them by the contributing healthcare systems, and they keep it alongside that harmonized mapped data. So the harmonized data is what's intended for research use, although the source data is also available to researchers. So centralized data like this is more usable if everyone uses data standards when they're collecting the data in the first place, because standardized data doesn't require as many transformations. And that's why we have standards. And yes, there are standards for race and ethnicity data. The most commonly used standard is the federal standard, which is shown here. And then this is essentially how that data is supposed to be structured according to the federal government and the National Academy of Medicine and HL7. So there are 5 minimum categories for race, which are shown here on that left column. And then ethnicity is shown in the center column, and that's a separate concept from race. Ethnicity only refers to Hispanic or Latino ancestry. Essentially, how the standard's supposed to be implemented is that everybody has a race, which is one of those 5 categories, and also an ethnicity, Hispanic Latino or not Hispanic Latino. And then there's more granular subcategories of race and ethnicity that can roll up into these larger primary categories. So for example, you could select a more detailed answer like Vietnamese, but for tabulation purposes, that subcategory should roll up into Asian. So this is how the healthcare institutions are supposed to be structuring their data, which seems clear enough, I guess. But we know there are all these data quality problems with race and ethnicity data. So what's actually happening? So this table shows all the harmonized categories for race that are in the N3C in order from largest to smallest. And you'll notice that the second largest category was no matching concept, which suggests that a significant amount of the data about patient race got lost at some point in the data pipeline. And you can see here that some clinical sites are still using outdated, deprecated concepts, such as non-white, which is number 16 here. And you can also see how, even though this is the harmonized data, these cohorts are still a little bit fractured. For example, Black should have been mapped to Black or African American, and there's some other categories here like other Pacific Islander and Native Hawaiian or other Pacific Islander that also should have been combined. So this is called the heterogeneity problem. And it's a problem because anyone who might be running a query on this database, like maybe they're trying to build a table 1 for a research paper, or build a cohort of Black or African American people in order to understand why that group has much higher hospitalization rates with Omicron, they're probably going to pull the information from one of these groups and then completely miss the other group. Or at best, they're going to have to spend a lot of extra time harmonizing the data on their own rather than actually studying COVID. So either these fractured groups are creating a lot of noise in your data, or best case scenario, you have this rate limiting factor of having to spend extra time harmonizing the data and doing the mappings yourself. So next I delved into what had been labeled as data that had no matching concept, which I called non-conforming data because it doesn't conform to the federal standard. And to look at this, I aggregated each category by the source values and I tabulated those results in order to find out how many patients had been given each encoding and how many ways each category was reported. And then I cross-tabulated those resulting categories by patient ethnicity, by data partner, and by data model. And then we used an inductive approach to sort the non-conforming data into these categories. So this non-conforming data with no matching category, a lot of the time, everything in those categories, which is things like other or missing, it's considered unusable and it's often ignored or dropped by data users. So what that means is that when we create cohorts by race, anybody in those categories will be excluded. And the bottom line here is that this is how, erasure can really inadvertently happen with data. The people in those categories are not going to show up in an analysis or in the results. And a lot of times they get omitted from research. And again, that's not necessarily a big deal if it's happening to all groups equally. But remember from that first study I did, the literature review, it seems probable based on the literature that there's going to be a disproportionate number of Hispanic, Latino, and American Indian people in this group of unusable, non-conforming data that has no matching category. And guess what? Yes. So the main findings with this study were that, yes, as in the literature review, Hispanic people were overrepresented in this non-conforming race data, as were American Indian and Alaska Native people, and Black or African American people to various degrees. And we could kind of reconstruct how that had happened and how people had wound up in these categories. And actually, each of those three groups had ended up there for very different reasons. So the data from the American Indian, Alaska Native population, for example, was deliberately obscured by the N3C by being placed in the other category. But the good news is that we could rescue some of the data and we could make it usable again and return at least some people to their cohorts. So this is a Sankey diagram that I made to show how the findings of this study might be applied. The data could be rescued or essentially transformed to be more usable. And it's possible to correct the data from over 45,000 patients that have been improperly mapped. When compared to examining race alone, combining race and ethnicity into a single unified category not only allowed the Hispanic Latino population to be better represented, but it also allowed us to decrease missingness of race data by 13.6% and reduce refused responses by 21% and reduce the amount of data in the other race category by 61%. So moving on to aim 3. So for this final aim, I wanted to apply those findings from aim 1 to show that these methods for improving data quality have a direct and measurable impact on study results. And I wanted to use a geocoded, integrated, or linked data set to explore that. So I decided that I would accomplish that by studying my own study. So a couple of years ago, I designed and carried out a cohort study in which I looked at the association between pulmonary exacerbations in people with cystic fibrosis and poor air quality days caused by wildfire smoke. And for that study, I'd used geocoded patient addresses to link an individual level health outcome documented in the clinical record, in this case, pulmonary exacerbations, with a community level exposure, in this case, poor air quality days caused by wildfire smoke. And that was a pretty straightforward cohort study that was published in the Journal of Pediatric Pulmonology. But I was curious about all the choices I'd made when transforming that data for analysis and all of those dozens of judgment calls that I'd made. So what if I'd made different choices? Would I have gotten different results? And I was curious about that because when we're preparing data for analysis or data munging or data wrangling, whatever your preferred term for the data preparation process is, while we're doing that, we're making choices about how to clean, transform, and integrate the data, and making choices about data quality issues like how to handle missing or inaccurate data. Data preparation is really the action step for improving data quality. So to study this, I developed an algorithm which prepared the data from my study on wildfire smoke and cystic fibrosis a variety of different ways. And I took those prepared data sets and I generated results from them using Fisher's exact test. So to build that algorithm, I broke the data preparation process I used into 4 discrete steps. And the first step was to validate the addresses of the patients in the data set, because I needed their addresses to assign each patient their readings from the air quality monitor closest to where they lived. The second step was dealing with missing addresses for the same reason, in order to match patients to information about air quality. And next, I matched the health information from each patient with the information from the air quality monitor readings closest to them, and thus integrating the 2 data sets. Because air quality monitor readings are only relevant within a certain radius, next I had to decide how far away a patient could live from the nearest air quality monitor and still be included in the study. And finally, I decided how long it might take after an exposure for a patient to develop the outcome of interest. In other words, I had to make a decision about lag times. So those are all the steps, but what different choices could I have made at each of these steps? So based on those 6 data quality improvement recommendations that I identified in aim 1, I came up with several different data preparation choices that might plausibly have been made. And some of those came from decisions other researchers made in similar studies, and some came from consulting with Dr. Erin Trimble at OHSU's Adult Cystic Fibrosis Care Center. And here's how the algorithm worked. So starting with step 1, the algorithm randomly selected one of the 3 methods for validating addresses. So in this example, it selected 1A from that first set of steps. And 1A is to validate the patient zip codes using a list of valid zip codes from the United States Postal Service. And then once it had completed that transformation, then the algorithm would move on to step 2 and select one of the 5 methods for handling missing addresses and transform the data again using that method. And continuing to randomly select methods from each step shown here and transform the data according to that selected method until finally the algorithm analyzed the prepared data set in order to find the odds ratio for the likelihood of a person with cystic fibrosis experiencing an exacerbation after being exposed to ambient wildfire smoke. So in this case, the combination of these nodes, 1A, 2C, 3C, and 4A, would produce a statistically significant result that tells us that a person with cystic fibrosis has 1.3 times the odds of experiencing a pulmonary exacerbation after exposure to wildfire smoke. But this is only one of 135 possible combinations of data preparation choices that could have been made. So in other words, there are 135 different pathways through all the nodes and steps. So the algorithm would generate all these data sets and then analyze them using Fisher's exact test. And this forest plot shows the resulting unique odds ratios. So some of the data sets generated the same result, and that's why this only shows the 93 unique results. But my point here is that there's a lot of variety, right? So the odds ratios range from 0.83 to 2.93, which means that depending on how that data was prepared, there could be no association between wildfire smoke and exacerbations, and nearly 3 times the likelihood of an exacerbation after wildfire smoke exposure. So keep in mind that the only thing that I changed was these data preparation choices. I used the same statistical test, the same data set, and I even did the data preparation steps in the same order. So clinicians give advice to their patients based on research results like this, and sometimes policymakers write legislation based on research results like this. And the choices that we make during data preparation can have a huge impact on these results. And they can make as much of a difference as things that we're required to disclose when we write up our research, like which statistical test we use. But despite the importance of these data preparation decisions, we rarely talk about them. So think about how much training you've gotten on how to select a statistical test, and then compare that to how much training, if any, you've received on how to select data preparation techniques. So with that in mind, I wanted to examine the variability in these results and learn more about where that variability might be coming from to see if any of the data preparation choices in particular might be responsible for that. So to look at that, I used Hedges G to get the effect sizes that are shown here, and I calculated the effect size by grouping the odds ratios together based on which nodes they pass through, and then I used the mean of those grouped odds ratios to calculate the standardized mean difference using the equation shown here at the bottom, which subtracts the mean of the grouped odds ratio for each step from the mean odds ratio for all results, and then divides that by the pooled standard deviation, the equation for which is shown there, and that part is called Hedges G. So I thought that the different methods for handling missing addresses would have a stronger effect, but the results showed otherwise. And actually the results showed that exposure classification, step 3, had a bigger effect size. And why is that? This swarm plot illustrates how decisions about exposure classification on node 3 can have a strong influence on which patients are represented in the research results, which in turn can have a big impact on those results, right? So by making a choice to exclude patients who live further away from the air quality monitoring station, you might prevent misclassifying people into the wrong exposure category, but it also excludes a lot of people from the research data set, which kind of both has this big impact on the result, and it effectively creates a research cohort that's entirely made up of people who live in cities. So that choice would essentially trade one kind of bias for another. And as researchers and data users, we have to be mindful of those trade-offs, and we have to be transparent about the representativeness of our cohorts. Okay, so that's all the research part that I did. Now I'm going to kind of summarize. But of course, these 3 studies that I've presented here today, like all research, have some limitations. Like for the first study, it's important to note that although some social determinants variables like race and ethnicity might have more thoroughly documented or easily quantifiable data quality issues, that doesn't necessarily mean that those variables are of poor quality. Having a larger body of research might just indicate that these variables are more accessible and therefore easier to study. Race and ethnicity, for example, are available as demographic variables in the EHR. They're relatively easier to pull than, say, something like patient socioeconomic status. In the second study, the provenance of the data from the National COVID Cohort Collaborative is limited, which makes it difficult to trace exactly how errors occurred. And in the third study, although my primary focus with that research was ultimately not epidemiological, it's nonetheless likely that the final study was somewhat underpowered because cystic fibrosis is a rare illness. In terms of contributions, my first study connected the concepts of data quality and bias and showed how failure to identify and address those data quality problems has the potential to limit the validity and reliability of efforts to understand and reduce health inequity. And it showed that the impact of these data quality issues was not equal across all races and ethnicities, and it identified a trend of problems with the categorization of Hispanic, Latino, and American Indian or Alaska Native patients. And my second paper showed that there can be significant challenges with the quality of race and ethnicity data in large centralized databases. My analysis also called attention to issues with the quality of some of the race and ethnicity data in the National COVID Cohort Collaborative Data Enclave. And critically, I demonstrated that data from some of the very groups hardest hit by the pandemic, American Indians, Black or African Americans, and Hispanic Latinos, that data is disproportionately affected by those data quality problems. So the N3C has since then set in motion a process which promises to make available the data on American Indian patients that is currently obscured. And I'm also working on another paper on ways that some of the data that was lost during that harmonization process can be rescued. And just as a general note, with those centralized multi-source databases, I feel like there's a lot of potential there for the field of informatics to make some really significant contributions, because we're still hammering out how to make data sets like that usable. And we've only just developed the capacity to store large amounts of data very recently. And my final paper demonstrates quantitatively that the conclusions that we can draw from our research analysis are highly dependent on how we prepare the data. And although previous studies have demonstrated the importance of data preparation decisions to the field of pharmacoepidemiology, to the best of my knowledge, this is the first study to show how these decisions can impact the results of social determinants of health research. So in conclusion, nearly everything we know about social determinants of health and health equity comes from studies conducted upon this real-world observational data. So if we want accurate insights into health equity, we need to pay attention to the quality of the social determinants data that we're analyzing. And I've shown that consideration of data quality and thoughtfully applied quality improvement methods might help prevent bias. I've demonstrated that transparency about these numerous data preparation decisions is critical if researchers are going to make accurate inferences from analyses. And my hope is that it can open a dialogue about how bias is introduced into data and normalize the practice of reporting data preparation techniques. So I want to thank all of my co-authors for their help and for many hours of brainstorming. And I'd like to thank the wonderful staff and faculty of OHSU, especially at DMICE and in the library. And I'd also like to thank my fellow students for their encouragement and camaraderie. And I'd like to thank Dr. Karen Eden, who's the person who gave me this opportunity in the first place, and gave me the pep talks and connections that I needed in order to succeed. And I'd especially like to thank my mentor, Dr. Nicole Weiskopf, who just constantly amazes me with her intelligence. And everything that I've accomplished has been made so much better as a result of her feedback and her input and her impressive editing skills. And I'd like to thank the members of my committee for volunteering their time to guide and educate me, and of course, my loved ones, some of which are here today, my parents and my son Otis and my boyfriend Cheyenne. So thank you all.
Great. Thank you. That was a very nice talk. I guess I will I'll lead off the questioning. Actually, I'll lead off with a comment, which is I actually realize what I told you yesterday about the arrows, that one slide that I maybe was a little too fixated on. If you think about all the combinatorial pathways through it, there should be 135 unique pathways through that data. So you don't need to fix that slide for your NLM talk. But my question, I was originally, as you were talking about N3C, I was thinking, oh my, this is significant that there's this, potential problems with N3C data, although it sounds like they're reacting to it. But that then, so actually maybe if you could elaborate a little bit more on that and how they plan to respond to that. But then kind of really more so looking forward, where do you see as the biggest opportunities for using this kind of methodology to improve other social determinants, or really all data in general?
Well, yeah, and I'd like to emphasize that this is a really relatively small, N3C is a huge database. So yeah, it's 45,000 patients, but that's out of millions. So I think it's altogether, we're talking about less than 1% of the data in their entire database. Yeah, and they are moving to correct the part about American Indians and kind of make that data available again, unobscured, or come up with a mechanism that would allow for it to be unobscured. And in terms of the applications, like I said, I feel like these really large centralized databases are becoming more and more common, and they do have a lot of those heterogeneity issues when it comes to harmonizing and mapping the data. And I think we do need to kind of work on how to make that work in order to be able to get actionable insights out of these databases, because they have so much potential, to have these nationwide databases. But right now, the data isn't as usable as it could be. And so I think informatics can kind of contribute a lot in terms of mapping those things. And a lot of that has to do with, perfecting these common data models and figuring out how best to take these individual encodings from different institutions and be able to get them to talk to each other and make sure they're the same thing. So yeah, a lot of it has to do with data standards and data models, and try to figure out how to get those to work together.
Great. I'll let others. There we go. There's a comment or question in the chat.
Yeah, so Nicole has a good point. So the N3C chose to obscure the data from American Indian Alaska Native patients to protect the sovereignty of those people, so that they could have control of their own data, and to be able to make decisions about how their data was used. Right, so the issue is more about just making that data available. And yeah, and to respond to it, Mina said, yeah, there can be issues about making data public depending on the number of individuals, because they want to obscure data that is less than 20 individuals, although that wasn't really the issue with this particular study. It was more that some of those smaller categories hadn't been rolled up into the larger main categories in terms for researchers to be able to use it. And the privacy issues are about, taking the data out of the N3C itself. Yeah, does anybody else, any other?
Looks like Chris has her hand up.
Oh, okay.
Yeah, thanks, Lily. Really great presentation. I thought it was really important how you brought everything back to effect sizes and kind of walked us through, what your thinking was on that. I'm curious. My question is around the fact that making a difference in the data, there's the absolute kind of what amount of difference did it make, but then there's the question of whether it made a positive improvement in the data or kind of was detrimental to the data. Like it's all, it's different, but some of those differences that you showed across the board, are things that might be viewed as bad and others, might be viewed as better. And I wonder if do you have any feeling about coupling that sense of how big the effect is with any sense of how negative it is or how positive it is in terms of what happens?
Yeah, that's a really good point. So essentially those effect sizes are kind of like a measurement of variability and not a judgment about like whether this was good or bad. It's just kind of like, well, this particular practice pushed pushed the end result in this direction. And so I think it's just like another thing for data users to be aware of in terms of like the choices that they make when they're preparing data, to be like, all right, well, this could potentially have a pretty like significant impact. And this is where we need to be most mindful about the choices that we make, right? So in other words, like maybe the takeaway is, okay, the effect sizes about classifying exposures, those have the biggest impact. So when we're choosing to do that, that's when we need to be really, really careful about the methods that we choose.
Thank you, really great.
Yeah, does anybody else have anything that they want to ask or any comments that they want to make? Oh, Michelle has her hand up.
Yeah. Hi, Lily. Great talk. So I was wondering if you had any ideas about just what you were talking about. You identified that third step as being the one that was crucial, that had the biggest potential impact on the results of your data. But, for most researchers, they're not going to create that tree of all the different permutations of the choices that they made, right? So, do you have any more general recommendations about how, like, you might find that you might come across that step, like be able to identify that third step had the biggest impact without having to actually enumerate every single possible, um, path through all your choices?
Yeah, so I don't necessarily think that that's like something that every, similar project should have to to do or run through, but I do feel like there needs to be kind of a body of research about these methods with regards to observational data. Like as we're getting to the point where we have this data is more available and we're using it a lot more, and we're stepping away more from those kind of traditional like clinical controlled, randomized controlled trial types of studies and going more towards using these observational real world data, that we need, informatics and we need researchers to kind of look into this and to tell these people who are using this data, like, look, this is what you need to do. So not necessarily that particular method needs to be reproduced by every single researcher who's using observational data, but there does need to be a body of research available to data users that they can look at and say, like, okay, like this is where we need to be careful as we go through like this data preparation process, or as we analyze this data. This is where we need to be careful. So that's kind of my hope, that there'll be this bigger body of evidence available for data users.
Great, thanks.
So Nicole, to follow up on Michelle's question,
Mm-hmm.
do you think effect size should be something you should be looking at when you make the decision of what to explore the quality on?
Yeah, I'm not sure if that's kind of like I'm kind of making up my own techniques like at this point, because because this area is so new. So yeah, I don't know if I would necessarily do that next time, but again, it's really helpful for kind of understanding variability and what the most important or most sensitive parts of the data preparation process might be. I don't know if it would apply outside of those integrated data sets or outside of environmental health research, but I'd like the opportunity certainly to try it with other data sets and with other studies to see what would happen and to see if it might be generalizable in that way. And I'd certainly encourage, like, if anybody wants to try to reproduce it and to try to do that same thing with the effect sizes and see if it's something that could be useful in different areas. Like, I think that would be great, and I'm happy to share the code and everything, which is it's in the appendix of my dissertation write-up. So something I want to make available to people to try to do on their own. Yeah, I agree with what Amina says about, yeah, we kind of need to incorporate people with subject expertise and imputation expertise and data science expertise too. Okay, does anybody else have any questions?
Okay, well, if we the public can leave Lily to her committee, and they will carry out the next steps. So thank you again, Lily, for a great presentation, and thank you everyone for attending today.
Yeah.